everyone, and good afternoon. My name is Nicole Magruder, and I am the Executive Director of Community Hero Action Group. Our mission is closing the gap in wealth and health disparities in the Black community. I am pleased to present Dr. Ayana Kersey-McMullen to our next session. She is going to tell us all we need to know about understanding stroke, the risk, and recovery. If you have any questions during this forum, please be sure to drop them in the chat. If you're watching this on Facebook or YouTube, feel free to type in your comments and we will still receive those as well. And without further ado, I will hand it over to you, Doctor. Thank you so much for joining us today.
Thank you. I'm so excited to be here. So I'm going to share my screen, get started, and I want to thank everybody for their patience as we work through these technology issues. You know, sometimes technology tries to stop us from being great, but we're going to keep it moving. So let's get started here. All right. So again, my name is Dr. Ayana Kersey-McMullen, and in addition to being the medical director for the stroke program and integrative wellness program at Good Shepherd Rehabilitation Hospital, I also am the owner operator of ASKM Enterprises and drayanaskm.com, which is a health and wellness consulting company. So I'm really excited to come and talk about stroke and stroke rehabilitation because it is something I feel very passionately about. And so we're going to get started. Okay. So I do not have any major disclosures. I am an employee of Good Shepherd Rehabilitation Network, and I am not receiving any compensation for this lecture. So let's just start by talking about stroke in context, because that's really important and how stroke is affecting us. Around 3000 BC, Imhotep, who was an ancient Egyptian physician and really the father of medicine, described stroke in one of the earliest known medical documentations, and that was the Edwin Smith Papyrus. And then in about 400 BC, so Hippocrates, who is known as the father of medicine, but really is a child of Imhotep, talked about apoplexy. And that was an ancient term for stroke syndrome. So we know that stroke has been around for a very long time if we're talking about 3000 years BC. Okay, so there are two main types of stroke, generally speaking, and I'm going to talk about those today and try to describe them in a way that makes sense to all of us. So the first type is the ischemic type, and ischemia literally means tissue death for the most part. So what can happen is you can have development of a clot or a clog in a vessel, and that can be because of atherosclerosis, buildup of plaque in the vessels. Or you can have a clot that moves from another place that's called an embolus, causing an embolic stroke. The long and short of that is that this clog in the vessel will cut off vital supply of blood and nutrients to the tissues of the brain, and that causes death of the tissue in that area. So that is an ischemic stroke. The other major type of stroke is called a hemorrhagic stroke, and hemorrhage means to bleed, bleeding. And the leading cause of that is uncontrolled hypertension. Now, some people can have aneurysms in their brain that can cause a type of hemorrhagic stroke, or they can have abnormal connections of blood vessels in their brain, and that can lead to a hemorrhagic stroke. But the most common reason for that's in the brain that can cause the tissues of the brain to be very sensitive or friable, we call it. And that can cause a hemorrhagic stroke. But the most common cause of hemorrhagic stroke is uncontrolled hypertension or high blood pressure. So let's talk a little bit about the risk factors for stroke, because these obviously are going to be very important to understand what our individual risks are. So I like to start talking about this from the standpoint of non-modifiable or non-changeable risk factors, because they're shorter and we really can't do much, but you still need to know them because they will weigh into your individual risk. So for everyone who lives beyond the age of 55, for every decade or 10 years that you live beyond the age of 55, there is an increased risk of having a stroke. So that's for everybody. Gender. Males tend to have more strokes than females, particularly at an earlier age. But as we age, women start to catch up to that number and exceed males, in part because we outlive men, generally speaking. Family history. People who have a family history of stroke, that meaning mom, dad, brothers or sisters, grandma, grandpa, if any of them have had a stroke, the risk of you having a stroke is higher. Why? In part because of your genetics. So the DNA that we pass down from generation to generation is a factor in that. But it is largely having to do with the other things that we pass down. Because we don't just pass down our DNA, we also pass down our behaviors and our habits. So there's the genetics and there's the epigenetics. And epigenetics is everything outside of our genes that has an impact on our health outcomes. So that is social determinants of health, that is habits and behaviors, it's how we eat, how we sleep, how we manage our stress. Do we smoke? Do we drink to excess? Are we using drugs? Do we exercise? All of those things, or environmental toxins, poverty, racism, all of those things are part of the epigenetic profile. So what we pass down from family members is a risk factor for having a stroke. Personal history. So people who have had a stroke are at higher risk for having a stroke, in part because the chronic diseases and the behaviors that were associated with having a stroke in the first place are still there. And if you have a physical issue or a heart difference that I'm going to talk about in a minute, if you still have those, which you're going to because it's something you're born with more often than not, then those things still put you at risk for having a stroke. Race. So people who are considered white race have a lower risk of having a stroke compared to Blacks, Asians, Native Americans, Hispanic, whether Black or white. And it's interesting because race is really a social construct. It's not genotypic, it's phenotypic. So the fact that people who are of a certain race have higher risk of developing certain diseases, I always find to be very, very interesting because of the fact that it is not based in genes so much as it is based in epigenetics, which we talked about before. Okay. Heart differences. So some people have something that's called atrial fibrillation, and that is an abnormal heart rhythm that increases your risk of having a stroke. Some people have valves that are sick, that are not normal, and that increases people's risk for having a stroke. In addition to that, there are some people who are born with something that's called a patent foramen ovale, which basically means a hole in the heart. And that hole does not close at the time of birth, and that increases the likelihood that things like clots move through that hole and cause a stroke. And that is something that we typically see in younger people when they have strokes, is that they have a patent foramen ovale, and often that is combined with a clotting disorder that increases their risk of having a stroke. So heart differences. And then we have brain differences. So again, we had talked a little bit about having aneurysms. So those are weaknesses of the blood vessels in the brain, causing an outpocketing in the blood vessel. Also having something called an AV malformation, which is an abnormal connection between arteries and veins in the brain that increases the risk of having a stroke. And also something called amyloid plaques in the brain can make the brain tissue more friable or more sensitive. And that again can increase the risk of bleeding that could cause a stroke. But all of those are what we call the non-modifiable risk factors, or things you can't change, but you still need to know because it does weigh into your personal risk profile for having a stroke. But these are the ones I love talking about. And these are the modifiable risk factors, or the things that you can change. So things such as coronary artery disease or heart disease, hypertension, hyperlipidemia or high cholesterol, diabetes, type 2 diabetes in particular, obesity, smoking, drinking to excess, drug use, particularly with things such as stimulants such as cocaine, and synthetic marijuana is actually known to cause some stroke activity as well. Amphetamines can cause stroke activity as well, bleeding strokes in particular. And then way down on the list are things like chronic migraines because of the spasms that are caused in the vessels of the brain when people experience of migraines, and also COVID is known to cause some stress. It can cause some system-wide clotting, which would be more on the line of ischemic stroke. So those are our modifiable and non-modifiable risk factors. And I'm going to talk a little bit more about modifiable risk factors because, again, those are the things that I get really excited to talk about, because there are things you can do something about, and it's a lot you can do about it. Okay, so let's talk a little bit more about the epidemiology or the statistics around stroke. So stroke is the 5th leading cause of death in the United States, and that's behind heart disease, cancer, COVID, and unintentional injuries when we're looking at the top 10 causes of death in the United States. Stroke is number 5. It's been number 3. It's been number 4 before COVID. I believe it was in the number 3 or number 4 status. Now it's number 5. But again, it has been long-standing a top cause of death behind things such as heart disease and cancer. And we know that heart disease is actually a risk factor for stroke. And so it really is important to understand this when we know that at least 48% of all adults in the United States have some form of cardiovascular disease. And this is largely driven by hypertension or high blood pressure. When we take high blood pressure out of that number, it's about 9% overall. But again, at least almost half of adults have some form of cardiovascular disease. So that's pretty serious and something to really think about as we move forward. Stroke is the leading cause of disability in the United States. And each year, about 800,000 people will have a stroke, with about 600,000 of those being a first-time stroke. So the majority of those strokes are going to be the first time that someone had a stroke. And I keep making that point about the first time because remember I said that having a stroke puts you at risk for having a stroke, for having another stroke. Okay. 2/3 of people who experience stroke survive, but about 140,000 of those people will die every year who have had a stroke, particularly when we're looking at the hemorrhagic or the bleeding type of stroke. It is a much more catastrophic type of stroke in the very beginning. Although interestingly enough, those people, even though they die more often than people who have ischemic strokes, if they survive, they tend to do better down the line. So about 1 in 20 people who have a stroke will die from stroke. Stroke mortality rates or death rates have decreased in the last 2 decades, but this is primarily limited to older adults. And what we're seeing is that the rates of stroke is actually increasing in younger adults, especially men in the age range of 35 to 44, which is very, very concerning for me. And I can tell you that just on an anecdotal basis, I have had a number of young adults in their 20s, 30s, 40s, and 50s now coming in my door who need treatment after having a stroke. And they're having strokes for the same reason that older people in their 70s, 80s, and 90s have strokes, is because of chronic disease. So again, very, very serious things to think about. The risk of having stroke in people of African descent or diasporans is times that of whites, Hispanics, and then Asians. I will repeat that. The risk of having a stroke for Black people is 2 times that of people who are considered white, Hispanic, and Asian. And again, a bit of that has to do with genetics, and some of that has to do with epigenetics that we talked about before. There is an overall decline in stroke. However, that is not the case in the Hispanic population, which has been increasing since 2013. The reasons for that are not entirely clear. Again, this is an ethnicity Hispanic that is broken down into Black and white typically. So why that is happening in the Hispanic population, I think, is not entirely clear. About the risk of stroke doubling each decade after the age of 50. People who live in what's called the stroke belt, or the southeastern part of the United States, the southern part of the United States, tend to have more strokes. It is more common to have a stroke when you are from a less affluent community. So poverty certainly has an impact on the experience of stroke. Again, that's epigenetics. But most strokes are largely caused by modifiable risk factors, which we talked about before. And 87% of people who have strokes are the ischemic type, which we talked about are the types where there's a clog in the vessel, not the bleeding type. So 87% of those are ischemic. And the risk factors for ischemia include things like high blood pressure. It includes diabetes, high cholesterol, obesity. Those things put you at a higher risk for having specifically having ischemia, an ischemic type of stroke, or having atrial fibrillation, where a clot can move from one place to another, as another high factor. So at least 80% of people who are having strokes, these are preventable events. Preventable. Again, just talking about stroke in context, a huge financial burden on the economy. According to the American Heart Association, between 2015 and 2018, 126 million U.S. adults had some form of cardiovascular disease, which we talked about. But the direct and indirect cost of cardiovascular disease in and of itself is about $387 billion. That's a lot of money. And a big portion of that is in direct costs, but some of that is in indirect costs due to productivity loss and mortality, things such as missed days from work, the cost of medical services, medication costs, and reduced societal contribution. And stroke itself contributes about 34 billion of that. So what are some of the side effects of stroke? Why is this such a serious disease? Well, I talked about before how stroke is the leading cause of long-term disability. Among stroke survivors, about 50% of them will have reduction in their mobility. In fact, according to the American Stroke Association, only about 10% make a full recovery from their stroke, meaning that they have no impairments whatsoever. 25% will recover with some minor impairments. Nearly half of them will experience ongoing adverse effects from stroke, and about 10% of survivors will go live in community housing situations such as nursing homes and long-term care facilities because of their ongoing disability or impairments because of stroke. We know that the process of recovery from stroke follows a fairly predictable, particularly for hemiplegia. And hemiplegia means basically paralysis on one side of their body. And the most rapid recovery and significant recovery occurs in the first 6 months to a year after having a stroke. In fact, some of the motor recovery will happen within the first 6 weeks of having a stroke. And so that's why it's really, really important that people will participate in rehabilitation early on after having a stroke by going to patient rehab hospital or going to nursing homes that specialize in taking care of people who have disability so they can get rehab or therapy. So let's talk a little bit more about the common adverse outcomes. I talked about hemiplegia. Hemi means half. Plegia is paralysis, so half of the body is most commonly going to be affected by having a stroke. That is one of the most common outcomes of having a stroke. You can have it's a poor prognosis if you have complete paralysis on onset, particularly for people who have what we call like brain stem strokes, or the strokes that occur in the brain stem, particularly the pons is a particular part of the brain where this happens. And also a poor recovery is if you don't have any hand function by 4 weeks. And the reason for that is because recovery of neurologic function occurs from the parts of the body that are closest to the spine and the brain, to the parts that are furthest away from the spine or the brain. So shoulders to fingers, hips to toes is the way that the body will recover from a neurologic standpoint. So if someone has they have some recovery of the movement of their fingers in particular at 4 weeks. That is a much better prognosis than someone who continues to have flaccid or completely paralyzed at the lower parts of their body, whether that's the hand or the foot. Post-stroke shoulder pain is very, very common. About 70 to 5%, 84% of people will have this. And this is often due to having something called spasticity, which is a neurologically based type of muscle spasm that prevents people from moving their limbs, and they can develop contracture. So if you've ever known someone with a stroke where their arm will be close to their body and they'll have flexion at the wrist, flexion at the elbow, and the arm is tight here, that is a form of spasticity. And so that can cause some shoulder pain because of altered shoulder mechanics. The muscles are not where they're supposed to be, and they're not behaving the way that they should, and that in and of itself can cause some pain. Sometimes people can have what's called subluxation or dislocation of the shoulder, and that is because of weakness in the muscles that control the shoulder stability. That in and of itself does not cause pain, but it does continue to alter the mechanics of the of the shoulder itself, and can cause some traction on some of the nerves, such as the brachial plexus, and that can cause some neuropathy or some pain. People very often will have tendinitis of things like their biceps tendon or their rotator cuff, or they'll even develop some adhesive capsulitis or frozen shoulder. And those things can cause some discomfort as well. But there are things that we can do to try to either eliminate that, prevent it from happening, eliminate the symptoms, or to rehab it. Also, people can develop some abnormal bone deposition or bone deposits in the muscles themselves, and that impacts the ability to move the joints as well. Again, there are medications that we can do. We definitely want to make sure that people are moving very early on after their stroke to try to prevent that. But when it does occur, there are medications and there are surgery options available to reduce that from happening. And then also edema or swelling. Often, what a lot of people don't realize is that the muscles are part of what keeps us from having swelling in our feet and which are the parts of the body that are close, furthest away, or are more dependent on gravity, for instance. So because of gravity, swelling can accumulate in the feet and in the hands, particularly in someone who isn't able to move their limb. So again, this is a good reason why we need to make sure that we're moving that limb to try to help the swelling or the extra fluid to move throughout the body. Okay. We talked a bit about spasticity, and again, this is something that we can prevent or try to treat. Although we expect it to happen, we can try to treat it with oral medications. And for patients who not tolerate oral medications, or those medications are not sufficiently managing spasticity, there are other options like chemodenervation, which is basically when we're using things like Botox or Dysport, and we inject those muscles to reduce the spasticity. I do that a lot in my office so that people will have better range of motion and it will not get in the way of their motor recovery. And then there are other things such as something called a baclofen pump, which is something that is a catheter is putting in the spine to help the spasticity in the lower extremities when people have extreme and severe spasticity, whether that's from a stroke, a spinal cord injury, cerebral palsy, MS, what have you. There's a number of reasons why people experience spasticity. And so those are some of the options that we have available. Other adverse outcomes include things like neurogenic bowel and bladder, which means that you have a dysfunction of your bowel and bladder. Incontinence is very, very often the most likely thing that people experience, but sometimes people are unable to empty their bladder. The bladder is not functioning properly, it's spasming, it's not opening in places where it needs to open, and therefore people are not able to urinate on their own. Again, there are medications and options to help with that. And sometimes incontinence, like I said, for both the bowels and the bladder. And for people who have ongoing bowel incontinence, that is a poor prognosis because bowel incontinence typically will resolve within the first 2 to 4 weeks. Swallowing dysfunction, not being able to swallow food without it accidentally going down the wrong pipe is very, very common in people who have had strokes. And so we often have to alter their food consistency and the liquid consistency to avoid things such as aspiration pneumonia, and work through therapy of improving the muscle tone in the throat, in the mouth, in order to prevent that from happening in the future. Aphasia, which is a language disorder where people often are either unable to understand the information that is coming towards them, or they are unable to produce speech. That's a sort of a simplified way of looking at it, but that is aphasia. And people have maybe even heard of it recently because I believe Bruce Willis, they said that he has aphasia, and that is a language disorder. But that recovery occurs, most likely the greatest recovery occurs within the first few months of after having a stroke. Depression is very common after having strokes, and it's really important that we address depression when people are having that, because the studies show that when people have depression and it is not treated, that there are worse outcomes in terms of recovering from your stroke when depression is not treated. So it's very, very important that we treat that, and we do that with things such as medications such as Prozac is the most studied medication for treating depression in patients who have had strokes. And then sexual dysfunction. And the reasons for sexual dysfunction may be because of the diseases that put them at risk for having a stroke in the first place, because things such as erectile dysfunction can happen because of diabetes and high blood pressure and coronary artery disease. In fact, some men don't even know that they have some of these diseases until they start to experience erectile dysfunction, and then they are diagnosed with diabetes, for instance, or coronary artery disease. Well, sexual dysfunction can also come with stroke as well. And part of that is because of the dysfunction that happens in the pelvic floor as a result of stroke, but it also may be related to the chronic diseases that they have, or it can be because of the medications that we're giving you to help you to get better. Sometimes that happens as well. Okay. What do we do to try to manage stroke? So I talked a bit about SSRIs such as Prozac that we use to help with motor recovery. That is one medication. We do use other medications such as Ritalin, which helps with recovery of aphasia, that language disorder that I talked about before. And it also helps with arousal, particularly for people who have had worse outcomes from their strokes, like the bleeding strokes, where they really have had catastrophic brain injuries as a result of the stroke. Ritalin is a medication that we will use to try to help the brain to give neurostimulation is what we call it. And amantadine is another medication that people may be more familiar with for Parkinson's disease, but it is a medication that helps to improve a neurotransmitter or hormone in the brain called dopamine, and that dopamine helps with arousal as well. So those are some of the medications we use as neurostimulants. I talked a bit about the spasticity such as baclofen. I talked about using Botox for chemodenervation. And then, of course, we have to treat things such as pain. Very often people will have neuropathic pain or nerve-related pain, or pain as it relates to the orthopedic injuries that they may have, like the tendonitis that they may be having in their shoulder. We obviously need to treat that because we don't want that to get in the way of people's recovery. So it's very, very important that after having a stroke, that you or your family member, people who experience stroke, that they experience rehabilitation very early on. And that's the reason why insurance pays for people to go to inpatient rehab in the very early periods of time, because the studies support us doing that. So that may be in the way of an inpatient hospital, a hospital where they specialize in rehabilitation, such as Good Shepherd Rehabilitation is a hospital system that specializes in rehabilitation, or some of the larger hospitals may have a rehab unit within their hospital in order to give people rehab and physical and therapies in order to recover from their stroke. But sometimes people also, if they have less severe symptoms, or they're not quite ready to go to an inpatient rehab, they may go to what's called a skilled nursing facility. And basically that is a nursing facility or nursing home where they also will receive physical therapy, occupational therapy, and speech therapy to help them in the recovery after their stroke. And then, of course, there's outpatient rehabilitation or outpatient therapy, where you're still at home and you are going back and forth a few days a week in order to receive therapy. And that will go along with seeing someone like myself, a physiatrist. So, and I neglected to say that in the beginning, I should have said that. So I am board certified in physical medicine and rehabilitation, as well as lifestyle medicine. So that means I'm especially trained to take care of people who have impairments and disabilities such as stroke, brain injury, spinal cord injury, amputations, chronic disabilities such as cerebral palsy or muscular dystrophy or spina bifida or multiple sclerosis and other things, orthopedic things and things of that nature. But I'm especially trained to take care of people who have impairments and disability. And I'm also board certified in lifestyle medicine, which means that I help people to learn how to make lifestyle interventions in order to prevent these things from happening in the first place, such as stroke, or to prevent them from happening in the future by making lifestyle adjustments. So when you have a stroke, you should always have a physiatric physician or a physiatrist or a rehab doctor like myself, who is going to guide your recovery, along with some of the other doctors that people may see, like a neurologist, which is a special type of nerve and brain doctor who does some of the same things that we do in physiatric medicine, but they still have some other parts of their specialty. Your primary care doctor obviously is going to be a big important part of that, and any other specialist who you may need to see because of your particular health outcomes. So I'm going to show you some pictures of some technology, that we use at our hospital for helping people to recover. So this is an example of something called an exoskeleton, which is basically a motorized biomechanical skeleton to help people to walk. And so you can see that this patient has the exoskeleton backpack on her back. And she has a walker there, and the two therapists here are helping her to walk with the exoskeleton. In fact, if you go on YouTube and look up Good Shepherd and exoskeleton, there's actually some videos there that you can see to watch people to walk with this device. But it's really interesting, and it helps people to relearn this very important motor recovery and life skill. So again, this is more gait training. This is called a light gait here. On the left is a treadmill with this person who's basically being held up, and the therapist is helping them to walk on this specialized treadmill to relearn the process of walking. The other side, therapist is teaching someone how to manage their balance again, recovery of their balance and their coordination is what's happening here. So all of this is part of gait or walking training. That's what gait is, it's walking or ambulation. Other assistive technology for the upper extremities. So this is called a Sabo here, this blue contraption here, and that helps people to use their arm as they're trying to recover their function. And then if you can see here on these legs here, that is a device that it provides electrical stimulation to the muscles to help people to walk. And we use that in the therapy setting, but also these are devices that can be purchased if they're covered by insurance, to help people with walking and ambulation recovery. So again, inpatient rehab is a big part of recovery after a stroke. And the reason why it's so important is because that we have all of the services that you need in one location. So we have the patient there, we have the patient support system and their family, and we have an opportunity to get information, because when people know better, they can do better, right? We have all the pieces in play that will help to build a wellness model. We have medicine, people like myself, we have nursing, therapy, nutrition, we have psychology, which again is very, very important. And then we also have health and technology center at our facility, and there are probably places like that at other places as well. And then psychology. So again, we talked about the importance of using psychology as a tool for helping people to recover. But it's not just things like talk therapy, but also incorporating things like mindfulness and yoga and deep breathing and things of that nature, to try to help people to recover from their stroke and also manage the symptoms of their stroke, their stress, their anxiety, their depression, and also things like blood pressure, which can be favorably affected by these techniques as well. So after inpatient rehab, new outpatient therapy, which we talked about, or go to skilled nursing facility level of rehabilitation if they need. Hopefully our goal is always to get people to be able to get well enough to go home if they have the support systems in place, and they also have the environment that will allow them to safely do that. But some people don't, have to go to a step down rehabilitation, which would be the skilled nursing facility, before they can go home. Now, I should say, I think I mentioned before that stroke, the earliest period of recovery is within that first 6 months to a year. That's the fast and earliest period of recovery after a stroke. People are going to make the largest gains during that time, but you'll continue to see motor recovery for up to 2 years and other recovery up to 2 years. And after 2 years, the recovery gains will be a little bit slower and a bit smaller, but you'll continue to have that. And then, of course, there's going to be ongoing monitoring of motor recovery, but also any adverse events, and doing things such as spasticity control, which we had talked about before. But I think the most important part, and I kind of touched on this before, is primary, secondary prevention. And that means, how do we prevent these things from happening in the first place? And then when they do happen, what do we need to do to prevent them from happening again? And the good thing is that, largely speaking, it's the same thing. We really need to start talking early on about the outcomes, health outcomes being directly related to lifestyle. We did not do a fabulous job of that in the medical community for many, many years, talking about how what you eat and how you live has an impact on your health outcomes, the epigenetics, what I talked about before. But we have a better understanding of it, and so that we're doing a better job. So physicians like myself, who are also board certified in lifestyle medicine, do talk about how food is your medicine. Food is medicine, and exercise is medicine, and we need to understand it as such. If we do that early on, before people are experiencing these kind of outcomes, then perhaps we can prevent things like heart disease and diabetes and obesity and high cholesterol and things of that nature. But when we haven't been able to prevent that doesn't mean that we can't do something about it. These are still modifiable risk factors. And so we really need to make sure that we're emphasizing the importance of diet, particularly a whole food, plant predominant or plant-based diet with minimally processed foods. And there's a study that I'm going to show you in another slide or two that talks about how there is evidence about the importance of using a plant-based diet to prevent chronic disease, physical activity. If you're anything like me, we grew up going outside and you didn't come into the street lights came on. So we were always physically active, but unfortunately, people are not as physically active as they used to be, in part because of progress and technology. And the reality is that progress and technology is actually holding us back in a lot of ways. So it's really important that we remain physically active, even if that means that we're only walking about 10 minutes a day. There was a study that came out from the Journal of American Medical Association that talked about just 10 minutes a day can have a profound effect on your health outcomes. So we have to keep moving. And if you saw my presentations earlier about the blue zones, that what we see for people who have longevity across the world, part of the reason why they live so long and so well is that they eat a plant predominant, whole food and minimally processed diet, and they remain physically active throughout their lives. So there are lessons that we need to really learn from that. Stress reduction is going to be very important, particularly when we're looking at things such as hypertension. Stress can certainly increase your high blood pressure, and of course it causes mental distress, and it causes chronic inflammation as well. So we definitely want to make sure that we are addressing things such as mental health and stress reduction. When possible, we definitely should be making sure that we encourage people to stop smoking and stop using substances that increase their risk of having strokes and other negative outcomes. And then obesity management. It's not something that is very popular to talk about, but the reality is that obesity is a chronic inflammatory disease that increases your risks of having heart disease, of having fatty liver disease, of having diabetes, of having strokes and heart attacks. And so we need to take out the aesthetics of talking about obesity and really talk about the health outcomes that are related to obesity and understanding the ways that we can prevent that, because our children are heavier, have more obesity than they ever had. And the reality is that is being reflected in children developing heart disease and diabetes at much earlier ages because of things such as poor diet and physical activity. So we definitely want to make sure that we're paying attention to that. Talking to young people early about the correlation between diet, exercise, and health outcomes, and understanding that these things are within your control. Genetics is one thing, but that's only about 20% of your health outcomes. Lifestyle is something altogether different. It really is about our epigenetics. Our lives are not happening to us, we are happening to it. And so we do have a locus of control. We do have an investment here in having healthy outcomes. So again, the importance of inpatient rehab, education. I strongly believe that when people know better, they can do better. And so I try to make sure that I'm giving my patients as much information as they can have so that they are empowered to make the choices that they need to make for their lives. I want my patients to do so well that they don't need me anymore. When my patients are doing so well that they no longer need Dr. Kersey-McMullen, I've done job. And that is that goal. And so giving that education is important. Making sure people understand how to manage their blood pressure at home and that to their primary care doctor. We don't call high blood pressure the silent killer for no reason. Most of that is because people are walking around with high blood pressure and not aware of it. And so they have some kind of adverse outcome, such as or having heart attacks or having kidney disease that they didn't know that they had because they had uncontrolled high blood pressure. So knowing your blood pressure numbers, knowing your numbers are very important. And the same thing goes for diabetes management. Knowing your numbers, knowing where you stand in terms of your blood sugar is very important. Knowing if you have pre-diabetes, and the thing that you need to do when you have pre-diabetes is do the lifestyle management. That's the first thing that we do for people. We don't put a pill in your mouth. We recommend lifestyle changes. Making sure that you're staying active, using walking programs, that you are paying attention to your nutrition, your stress management. And then this also gives us an opportunity to talk about things like exercise, sleep, mood management, and sexuality and sexual dysfunction. And it's really important that we talk about sexuality and sexual dysfunction because very often people think that when they have strokes, that they can no longer participate in intimacy and sexual intimacy. in addition to that. And that absolutely is not true. If you're medically stable, not only do I say that you should participate in sex, but it's also good for you. Intimacy is very, very important for you as long as you are medically stable, and you can participate in that as long as your blood pressure is stable and you're not having any symptoms. In addition to that, it's important for doctors like myself to bring it up, because often people will be suffering in silence and they won't talk about the fact that they're having sexual dysfunction because they're embarrassed. So I'm the doctor who talks about it in your appointment. If I can talk to you about whether or not you're having a bowel movement and if you're having urinary incontinence and all these other things, then I can ask you whether or not you have any concerns about your sexual life. Very respectful way, obviously. So. And this is the study that I talked about. I talked about plant-based nutrition, reducing the likelihood of developing risk factors related to stroke risk, hypertension, obesity, diet quality, diabetes, and lipid profile. And that is basically just supporting the idea that having a whole food plant-based diet is going to be healthier, because we know that people who have diets that are heavy in animal products such as beef, pork, chicken, fish, all of the meats, that they have a higher risk of developing these high blood pressure, high cholesterol, obesity, cancer, stroke, and heart attacks. We know that for a fact. We didn't always know it, but we do know it. There is a slightly higher risk of hemorrhagic stroke for people who have vegan diets, and that is related to not getting enough B12 supplementation or B supplementation. And so you supplement your diet with a vitamin in order to do that. So in conclusion, from stroke is not a marathon. It's a marathon. It is not a sprint. It takes time to recover from a stroke, but you can if you have the right team around you. But the most important things that I want you to take away from this talk today is the importance of primary and secondary prevention. These are key components in recovery, as well as ongoing risk factor reduction and remaining healthy and abundant and having a good life. So if you have any questions, I'm very, very happy to answer those now. I hope that all of that information was understandable. Here is my contact information. If you want to ask any questions, you can go to my website directly and go to the contact section. You can also find me on LinkedIn or on IG at Dr. Ayana SKM. And if you want to make an appointment to come and see me, you can come see me at Good Shepherd Rehabilitation Hospital, and that is the number on the screen. So I'm going to stop sharing so that if there are any questions, anyone can ask those now. Oh, I see some questions on the screen. So, okay. So it says, one of the questions is, are there any tests that can be done if someone believes they have experienced a mild stroke but never went to their doctor, drooping of the mouth for a day? Okay, that is a fantastic question. Yes, the first thing you need to do is go to the emergency room of your brain. Okay, anytime you experience any of that, whether that's drooping of the side of your mouth, any weakness, any confusion, changes in your equilibrium or your ability to maintain your balance, you need to make sure you're going to the emergency room and getting that checked out. It's better for you to go and it's a whole lot of nothing than you not to go and then it's very, very serious. So yes, there are tests that you can do, and the first thing that we're going to do is do a CAT scan of your brain, and that will be followed up with other things. Thank you for that question. The next question is there any way to get therapy to regain movement with the spasticity that we talked about? Absolutely. Physical therapy and occupational therapy are things that you're going to be doing to help to reduce that spasticity. And again, by seeing a physician like myself, there may be medication such as the Botox chemodenervation that we can do to help reduce that spasticity, and that will also aid you in your therapy as well. Now, I should caution you that if you have had spasticity for a long time, you can develop something called contracture, where the muscle shorten and then you can no longer move that arm. So it's important try to get early interventions for that, so that your arm or leg basically doesn't get stuck. But certainly come and see a physician like myself. You can come and see me at Good Shepherd, and we can talk about that more. But yes, there are interventions for that. And I think those were all of my questions. Do we have any other questions that you're aware of? No? Okay.
Nope, that's it for now.
Okay. Thank you. Thank you so much.
And thank you so much for sharing all of your wisdom. I really appreciate actually today's conversation, and it's actually near and dear to my heart. I used to spend my summers in the South with my grandparents, and we used to have fun and pick peaches off the trees and learn how to garden and all that good stuff. And I didn't think about it until I got later in life. And when I got a little bit older, I'd look at my grandmother and I would ask the question, like, why can't she speak? I've never heard my grandmother speak. And she had lost mobility in one of her arms.
Mm-hmm.
And I just think about like the disparities that are out there. This was like over decades and decades ago. So just wondering what her quality of life would have been like if she probably had the proper follow-up, and how that affected her, her family. She had nine kids, and all went on to do great, things, but you just still wonder how that impacted everyone's life down the road. So what you shared today is huge, and I think there's a lot of people that needed to hear it. And unfortunately, we don't understand what's going on with us, and we don't get the treatment, and then we don't understand what the true treatment should be. Yeah. So we still don't receive it, even though we're in 2022 and it's out there. But if we don't have the education, we can't be strong advocates for ourselves. So, so I really hope.
I'm sorry. I was just going to say advocacy is so important. Learning how to advocate for yourself and asking the questions to that. And I talked about that earlier in one of the other talks, is knowing the questions that you need to ask your provider in order to get that information. And don't be afraid. Understand that you have rights. You have the right to ask these questions. And if you're not getting your questions answered, ask somebody else. Okay. Everybody has a boss. So ask other people who can provide that information. And again, I'm very happy, answer more questions if people have them. But the point that you're making is such a strong point, is that very often in our community we just don't have the information. But now with technology, there's so much there that you can get access to, and some of that is sometimes just knowing who to ask and when to ask.
Yes, absolutely. So thank you again for your time, and all of Dr. Kersey-McMullen's contact information. I know she's repeated it a couple of times, but you can also find information over on the speaker section. Click on her name and you can find all of her contact information. If you think of anything after today's session, this session is recorded, so it will be uploaded, so those that attend the conference later in the week can still watch it in case some folks missed it. And then at the end of the week, we will start to upload all of the recordings for the week to our YouTube channel, and we'll send that out to everyone that is registered for the conference. So thank you for watching this session so much, and thank you to you again, Doctor. And thank you to everyone that's watching. And we are going to shift over to our last session of the day, Fast to Slow, examining the science of intermittent fasting. So I will see you all probably in about 3 or 4 minutes. So just pop over there to the next session. All right. Thanks. Have a good afternoon. Bye-bye.